So this is the document we're talking about. It was published last year, and it came out as a much-needed official statement to guide our practice in the field of appendage occlusion, which, as you know, it's quite a novel approach, and so it requires to have a solid ground on which we base our everyday practice, which is not always easy, particularly making some decisions that we will discuss later on. The problem that I think the panel had to face was the source of evidence, which is not as complete as we want it to be, because we only have two randomized studies, the PROTECT-AF and the PREVAIL. You have already seen the data of this study, but the vast majority of evidence comes from observational studies. They are, with some exceptions, the very small study, usually single-center studies with a single device, and with the notable exception of the study of Dr. Tsikas. They usually tend to have a short follow-up. So I will show you the data of a meta-analysis of these studies, and it ended up that after more than 300 publications, they had to select only 19 studies, but we shall see. So this is the result, the statement that was made by the authors of the PROTECT-AF. You see that the probability of non-inferiority in these studies comparing LA occlusion with warfarin was more than 99%. So it was a positive study showing that you have efficacy of the treatment compared to oral anticoagulation. But, and most interestingly, the efficacy was maintained at 4 years follow-up, which is, in my opinion, extremely important because particularly for cost-effectiveness analysis, which unfortunately is going to drive many of our decisions, it's important to show that the effect is persistent for a long time, because this is a technique for which we have an upfront payment, and we have to show that the effectiveness lasts long enough to justify the expenditure, which it's a way of guiding medicine that I completely disagree, but is something that we have to live with. And instead of showing you singular data, we have practically no time. I have decided to find this meta-analysis of randomized studies. Was published, I think, a couple of years ago or last year, and it is an analysis of all the published evidence. They ended up analyzing only 17 studies because they were with high number of patients, a relatively high number of patients, and with a reasonable follow-up of at least 1 year. This is the complication rate in the total population submitted to the randomized. The observational studies is quite high, as you can see, but you know that these registries usually include very fragile patients, which are bleeders with lots of comorbidity and very high risk of stroke. And so you can expect to have some procedural complication, which is, in my opinion, an acceptable range. But the type of population that has been admitted to the study probably helps us to understand why in this meta-analysis the effectiveness of left appendage occlusion in the observational study is much higher than in randomized study, and even in these large pharmacological mega trials on NOACs, so large that only pharmaceutical companies can afford to pay them. So this is what we have. And this is the last study that was published January this year. It's a Spanish study. It's the Iberian registry, 2 years follow-up, and it is pretty much in the line of all the previous studies. But please note that all observational studies, deal in comparing what you clinically observe in your patient to what is the expected outcome of the population. And to quote Alexander Pope, blessed is he who expects nothing, for he shall never be disappointed, because this is precisely what happened, in the PREVAIL study, in which the control population, to quote the study, overperformed. And so the event rate was much lower than expected. So we have to keep in mind this when analyzing the observational study and using them for building up our clinical decision. But this is all that we have. And we are not going to have anything new in the near future, because I was looking how many randomized studies are now ongoing on left atrial appendage occlusion, and this is what we have. One German study, which is evaluating left atrial appendage occlusion in patients with end-stage renal failure, and one surgical study. And as doctors, we cannot just see what happens to our patient when we have a reasonable way of treating our patient that have no other option. And so I believe that keeping in mind the limitation of the observational study, I think that the panel of the consensus statement made a great job to reach some conclusion, which I have to say I find quite reasonable, and with some exception, I completely agree. And I think that with this, we will briefly discuss these topics, which is indications, standards for operation in centers, information for registries and studies. I think the hot topic is probably this one. And the possible indication is occlusion as a replacement, as an alternative, as a complement to oral anticoagulation, and as an adjunct to AF ablation, which is a topic of my particular interest. So usually the indication that is accepted is patient with high risk of stroke and contraindication or proven intolerance to oral anticoagulation. This is already in the guidelines with some caution from the authors. So the definition of contraindication: history of significant bleeding or life-threatening bleeding of the source of which cannot be eliminated. But then we have other patients in which we don't have the previous bleeding, but they are at very high risk of bleeding. Patients in triple O.A.C plus double antiplatelets. Those are the worst patients that you can find in your practice. Patients that are not well characterized with the Hasbleed and Charvas score, like patients with cancer, patients with end-stage renal failure. And of course, those patients with end-stage renal failure, they present high-risk stroke, and they are very, very difficult to treat. So I think those are the indications that have been accepted by the panel. But do they bleed just because they are on warfarin, or is it going to be the same with NOACs? I completely agree that in the absence of further data, patients that are on full dose of NOACs, they should be considered to have a contraindication equal to warfarin. So I think this contraindication is not only due to the use of warfarin, but also to NOACs. Sorry. Keep in mind that unfortunately, we are not having, and we are not going to have in the near future, any data comparing NOACs with left atrial appendage occlusion. And naturally, we have a gray zone, which are patients that tend to bleed, but they don't bleed spectacularly. They keep bleeding. Usually, they are patients seen by the gastroenterologist. They have frequently to start and stop oral anticoagulation. This poses them to a very high risk of bleeding. Should we treat this patient or not? The opinion of the panel is that they have a reasonable indication. And then this is a difficult topic to treat. Patients that provide us an informed refusal to oral anticoagulation. They know that they have atrial fibrillation. They know that they should be treated with oral anticoagulation. They just don't want to take it for a number of reasons, which is sometimes they are quite silly, sometimes they are quite reasonable. So what should we do in these patients? In the opinion of the panel, and I think this is probably what all of us do in our everyday practice, is that the LA occlusion should be mentioned, but keeping in mind that saying this patient that oral anticoagulation is the standard of treatment, we don't have definitive data. There is a reasonable expectation the left atrial appendage occlusion works, but we do not know precisely how much it will work and how much better is for the patient to take drugs or appendage occlusion. So the decision should be made with the patient informing him. So this is the flow chart that we have. Patients that refuse O.A.C despite adequate information, they have contraindication, they take NOACs, they don't want to take it, or they're just intolerant to them for some reasons. LA occlusion can be presented to these patients, keeping in mind that they have to be treated with antiplatelets. As a complement to oral anticoagulation, we see very frequently patients that have strokes with oral anticoagulation, or at least in our practice, we do AF ablation and we have to do transesophageal in this patient, and we see at least 5% of patients with full oral anticoagulation that have a thrombus in the appendage. So what do we do in this patient once the appendage is free? And I think that it is a good indication, as stated by the document, to treat this patient with left atrial appendage occlusion as an adjunct to oral anticoagulation. As an adjunct to AF ablation, in the same procedure, doing appendage occlusion and AF ablation, there are no data, and so the document leaves you free to think what you prefer. And I think I have to prepare to say that in my personal experience, we don't do this, because either ablation works and the patient remains in sinus rhythm, and so you can stop anticoagulation, which is the aim of the game for us involved in AF ablation. And the problem is also that in these patients, the guidelines state quite clearly that ablation should not be performed in patients that cannot be treated by anticoagulation, because by ablating, you carpet bomb the left atrium, you completely de-endothelize it, and the source of emboli in this patient is not the appendage but the left atrium itself. So you can plug the appendage as much as you like, but then you are left, at least for 2 months, with the left atrium without endothelium, and so those patients can have a stroke for other reasons. And the stroke rate after ablation, I have to say, fortunately, is extremely low. So this is the other guidelines. We have to treat these patients with antiplatelets after the procedure, which is a problem, because if they are bleeders, they will bleed in double antiplatelets, they will bleed in aspirin as well. And the problem is that we don't know what to do with antiplatelets, and we know that we keep those patients indefinitely in aspirin just because of the assumption that they have a foreign body in the left atrium, and we have to do something, and we give aspirin. I think we are ready to start to do some registries to understand when we can stop aspirin, because if we want to reduce the bleeding risk, sooner or later we have to stop aspirin. So standards for operation and centers, this is quite straightforward. We need to have, before implanting, as a main operator, you should have theoretical courses like this one, which is an excellent one, you have to say. Then bench training is very important, because you understand a lot of the anatomy of the left appendage on models. It is important to have proctoring during the initial experience, and most importantly, centers must know very well, and they should be practical on the technique necessary to treat complication, pericardial centers as snaring. And you will see how fun is going to be the fishing expedition for snaring, but it can be also very, very difficult. And of course, practice makes perfect. The more you do, the better you are. Lay occlusion requires a procedural team, so you're not just the operator does the procedure. All the team is important. You have to have a very good echocardiographer. Your nurses have to know what to do. The anesthesiologist has to know what to do. So all the team has to be familiar with it. And then you have the tricky issue of can we do this without cardiac surgery on site, or can we do? The recommendation of the panel was that you can do without surgery on site, provided the maximum time to reach the operating room is 60 minutes. So one way of doing that, you hire the stick to drive your ambulance, or you have it in your hospital. I have to say that in most hospitals, probably transferring a very sick patient from your cath lab to the operating room will take probably 60 minutes. So I understand that it was quite a diplomatic effort